Good morning, everyone. Welcome to Rounds, April 5th. I will go ahead and get started. So, first case is are both eyes from a 14-month-old Bernese Mountain Dog Poodle mix, also known as a Bernedoodle, apparently. History of blindness prior to adoption at 4 months of age, and then presented in June for discharge of both eyes, diagnosed with retinal dysplasia, retinal detachment, KCS, and glaucoma in the left eye. So bilateral everything else, but glaucoma in the left eye. In January, glaucoma developed in the right eye. And then eventually the IOP in the right eye was non-responsive to medical management. And then they decided to enucleate due to blindness, et cetera, et cetera. So we received both eyes. And they're both pretty similar, which is interesting. So we have the lens in the center here, and the most obvious lesion is that the retina is detached. So you can see it forms this little tornado that comes up from the optic nerve head, and it sort of wraps around the lens. And that is the most obvious of the gross lesions. So now we will go ahead and jump into the histo. And I will show the subgross, but actually the subgross is not that exciting. But so cornea, the ciliary clefts and trabecular meshwork are not apparent at this low mag, or any mag for that matter. And then the lens, I think there might be a cataract there. And then also the retina is detached. We aren't sampling the entire tornado, but from this low mag, you can kind of appreciate these white spaces in it, which are areas of retinal edema, but we also call it retinoschisis. So we'll go ahead and jump right in. And both eyes were very similar, so I can show you both. So we'll start here. This is our little extra gonio slice, we call it. So as I said, at low mag, there's no ciliary cleft, and you can't identify the trabecular meshwork. What we do have, where should they be? They should be there should be a space here between the peripheral cornea and scleral stroma and the iridoid stroma, and we do not have that space. And then the meshwork is sort of a meshwork of delicate collagenous beams that should be right back here, and it is not present either. So when we go higher mag, and we look at the terminus of Descemet's membrane, which is here, it actually forks, it arborizes, and directly contacts iridoid tissue, which is continuous with this tissue here. So that is an abnormality of Descemet's membrane, very similar to what we call goniodysgenesis. This is a 14-month-old dog, and so we also want to consider the possibility of something called anterior segment dysgenesis, which is an earlier onset or recognition of malformation of the trabecular meshwork and iridoid cleft and glaucoma. This also has a nice pre-iridoid fibrovascular membrane, or epiphyme, as we abbreviate it. And epiphyme, in this case, well, before we get to the epiphyme, let's go and look at the rest of the angles. So this one here, whoops, it's very off center if I'm not looking at. Once again, that ciliary cleft and trabecular meshwork are not apparent here. And what we do have is the epiphyme, which kind of widens in this case and connects directly to the end of Descemet's membrane. So we have a peripheral anterior synechia on this side. And it is a similar story on this side. So no ciliary cleft. Some of the meshwork is actually back here. You can actually see it. And then there is also that pre-iridal fibrovascular membrane on the front of this iris leaflet as well. Another thing to look at or to try to evaluate to diagnose anterior segment dysgenesis is that where are the aqueous humor collecting channels? So they are back here, and these little channels are where the aqueous humor should be flowing out. But they're quite posteriorly displaced. They usually should be up here in this region where the trabecular meshwork is in the ciliary cleft. So they're posteriorly displaced in this, which is a part of this patient's issues. So I mentioned there was a cataract at low mag. And so here, when we look at the posterior lens capsule, we have some lens epithelial cells lining it, and there should not be lens epithelial cells there. And so we call this posterior migration of the lens epithelium. They normally only line the anterior lens capsule and the poles of the lens. And then in addition to that, we also have degeneration of the cortical lens fibers. And so these sort of big purpley guys are called Morgagnian globules. And the ones with nuclei in them, like this one right here, is called a bladder cell. So these are the histologic hallmarks of cataracts. And then to look a little bit more at our retina, so it was not sampled perfectly in this section, but we can see it does lead back here to the optic nerve head. We're going to look at it right here. So even at this mag, you can appreciate all these white spaces in here. So that is what I was calling as retinoschisis. Retinoschisis is a form of retinal edema. It typically develops between the internuclear layer and or in sort of the internuclear layer or in the interplexiform layer, which is here. And this can occur or develop as a result of retinal detachment in an adult dog, but it can also be a congenital lesion. And actually in humans, it is commonly maybe a congenital lesion, which is diagnosed early in childhood. And it's associated with retinal detachment. To corroborate long-term retinal detachment, we can look at the photoreceptor inner and outer segments, which are very short in this instance, or in this area. And that is something that also develops as a result of long-term retinal detachment. We're always taught to go look at the retinal pigmented epithelial cells to decide if they're hypertrophied, to corroborate or confirm true retinal detachment. And these guys are a little bit rounded, so we've got some mild RPE hypertrophy here to confirm retinal detachment. So they diagnosed retinal dysplasia. I'm not quite sure what exactly they were looking at to diagnose that. It may have been part of the retinal detachment, or they may have seen something in addition to the detachment to diagnose that. But I have a hard time confirming that based on the fact that the retina is detached. Normally for us, retinal detachment is when there's jumbling of the retinal nuclear layers and often pseudorosette formation.
Dysplasia, right?
Dysplasia. Thank you. Dysplasia. Sorry. Okay. So but the other eye is actually identical to this. So that we had very similar lesions in both eyes. And so let's go to our diagnoses here. So most important here, we have anterior segment dysgenesis, cortical cataract, which was juvenile or congenital, diffuse retinal detachment with extensive retinoschisis, and then glaucoma in the left globe, which I consider to be congenital or juvenile. Yeah, so just an interesting case. So anterior segment dysgenesis is a malformation of that iridocorneal angle and the filtration apparatus for aqueous humor outflow, which leads to decreased aqueous humor outflow and typically glaucoma. So elevated IOP and then glaucomatous degeneration of the retina and the optic nerve. It is similar to goniodysgenesis in function, but the morphology is a little bit different. So this morphology is a little bit better for, in this case, was a little bit more consistent with anterior segment dysgenesis. But the end result is the same, is that they end up with glaucoma. The glaucoma caused by what we call anterior segment dysgenesis usually occurs earlier in life, about under 2 years of age. And we often only get a single eye from patients with this. And so we actually are not quite sure at this point how frequently it is bilateral. So this was an interesting case because we got both eyes at the same time, which had very similar lesions. But to our knowledge, it can be only a unilateral diagnosis or lesion, whereas goniodysgenesis, which we typically are diagnosing in older animals, or adult at least, older adults, that is typically a bilateral disease and leads to bilateral glaucoma. Well, I shouldn't say that. It's typically a bilateral malformation. Dogs with goniodysgenesis don't always develop glaucoma. But okay, so next case. Any questions about that one?
Sorry, just real quick. So for anterior segment versus goniodysgenesis, you're using clinical presentation more than actual pathologic.
So it can get a little bit tricky, but the age of the animal is definitely a key feature of that. Often in anterior segment dysgenesis, the end of Descemet's membrane just tapers and it meets irritable tissue, but doesn't necessarily arborize and contact irritable tissue very much. In this case, it did actually arborize in that one angle that I showed, one area of the angle, I should say. But often it just tapers and then there's just a lack of ciliary cleft and trabecular musculature. Okay.
Looks like a more profound lack of development of the corneal angle than one of these genesis.
Okay.
But also definitely the clinical history and age.
There is also the displacement of the collecting channels and potentially hypoplasia of the scleral venous plexus, but those aren't necessarily consistent features in every case.
All right. Let's move on. Dang that clock. All right. The next case is a 12-year-old German short-haired pointer. We got the history of extensive scleral / limbal mass of red, multilobular appearance. Biopsy of initial, well, we'll talk about that later. Worsening within 3 days despite triamcinolone injection and topical corticosteroid. Ophthalmos and secondary glaucoma, anterior uveitis. There's an area, something of iris appeared thickened. So the iris appeared thickened in one area. This is actually bilateral disease. So the dog has severe uveitis and scleritis in the other eye. They also submitted a fragment of red raised mass arising from the skin near the ear. And then also the eyelids, I think, were affected as well. So there was a mass in the eyelids. Sometimes I'm never sure if they are submitting their clinical information from like 3 weeks ago, and then the dog showed up for enucleation, and then they just didn't update the clinical stuff or not. But anyway, so here's the globe. And we can see that there is a white mass that effaces the limbal sclera. It sort of abuts the cornea here. It extends back into the limbal sclera. And then you can see similar white material here in the choroid on this side and on this side over here. The retina is detached and there's sort of reddish vitriol. The vitreous itself is kind of reddish and there's some red material under the retina as well. So there's some hemorrhage in this eye. The iris here is maybe a little bit stuck to the lens. So we've got some posterior synechia. And on this side, the iris is sort of outlined or highlighted by this white mass that's sort of on both sides of it. So here is the globe. This was submitted in an extra large cassette, so it's in an extra large slide. And so there's a bit of artifact because it doesn't fix very well when it's submitted in an extra thick section. But anyway, so here's the cornea right up there. And the anterior chamber and the lens. But here's that side that was quite affected. So there is a very dark purple mass here, which indicates that it's markedly hypercellular. And then it extends back into, it effaces the sclera and it extends into the anterior uvea and into the choroid, which is right here. Here's our optic nerve. And then it's also in the episclera here. And also here's that iris leaflet that was just kind of highlighted by the mass. So we're gonna jump right in here. So the morphology of the cells is not great in this area. So we're actually gonna head back to the choroid where it was better preserved and better fixed. So we've got dense sheets of cells, and even from this magnification, you can start to pick up some really big cells. These cells are round and they have fairly discrete borders. So this would pass the tweezer test, as Dr. D would explain, meaning you could imagine taking a very tiny pair of tweezers and picking out an individual cell and not disturbing its neighbors. So this is characteristic of a round cell population. And then as we go higher mag, we start to see these guys even more better. So we've got great variation in cell size and nuclear size. And then also occasionally there are multinucleated cells like this guy right here. There's a binucleated cell here. This nucleus is indented. And so we've got a very pleomorphic round cell population. You can also pick up some mitotic figures. Here's one right here. And then we move up into the surface of the choroid. You can actually follow that. Try not to make everybody sick here. Oh, there's a beautiful one. So, oops. So you can see that the similar neoplastic cells are in the choroidal blood vessel lumens. So these cells are either coming or going from this eye. We're not quite sure which. So we've got, let's see what other kinds of lesions we have. The retina is detached. No question there in this case, whether that was real or not. We've got a really thick pre-iridal fibrovascular membrane on the front of that iris. That's a really nice one. So the anterior border of the iris is right here where that dark line is. There's typically a line of pigmented cells in irises that are normally pigmented, i.e. brown. And then on top of everything in front of that is the pre-iridal fibrovascular membrane. And a pre-iridal fibrovascular membrane in this case is probably forming as a result of the neoplasm. Neoplastic cells often produce a lot of vascular endothelial growth factor, which initiates the formation of blood vessels and this membrane on the front of the iris. And in fact, in the last case, I meant to mention that the PIFM present there, the pre-iridal membrane, was probably associated with the retinal detachment. I forgot to say that. Anyway, so there's a cataract here as well with some cortical lens fiber liquefaction. But anyway, so let's talk about the meat and potatoes. So we've got a round cell in this globe that is very pleomorphic, round cell neoplasm that is very pleomorphic. And so this is strongly suggestive of histiocytic sarcoma. We did not actually do IHC in this case, but as I mentioned, they did submit the mass from around the ear. And this is a little bit unusual for us to get such nice corroborative samples, but here's the ear mass. And we can appreciate that it's a similar population of just sheets of very pleomorphic round cells. And the eyelid mass as well that we mentioned was also a similar population of cells. So our assumption is that this is histiocytic sarcoma. They actually did a biopsy of, I think, the scleritis earlier, and it was diagnosed as granulomatous scleritis by the service that evaluated that biopsy. And certainly the morphology of the cells is consistent with a histiocytic population. And it's always hard to say what exactly they sampled when they sampled the scleral lesion. So it could have been that there were some inflammatory macrophages or something like that in that area. So they call it granulomatous scleritis. I don't know how long ago that had been done, but it is kind of sad that it got to this stage. I mean, they couldn't really have probably done much anyway at this point, even at that point for this dog. And I assume that the severe uveitis and scleritis in the patient's other eye is also associated with the histiocytic sarcoma.
Our first histiocytic sarcoma of the sensory organs.
Yeah. What was that, Casper?
Eye and ear.
Okay. Anyway, so sad story for the dog.
gonna say, it actually looks a lot like an aesthetics seminar.
Oh, yeah.
Oh.
Great.
That would be more interesting.
You're right.
Was it a male?
Now we're gonna go order a, no, it was a spayed female.
That makes it harder.
Maybe we should go order a CD204 now. Anyway, so I figured I diagnosed histiocytic sarcoma as being the most likely one, but it could be a very anaplastic lymphoma, which I thought was less likely.
Yeah.
So it's unusual for us to get, or for it to be in like cutaneous stuff for us. Usually histiocytic sarcomas that are in the eye are more like internal, like visceral lesions that they don't know about until they stage the patient.
And this was not the brain.
This was not the Bernedoodle, believe it or not. This was not at all. Okay, now. Oops. I'll put you up next, Megan.
All right. So our next case.
Oh yeah, sorry, we didn't actually talk about the prognosis of histiocytic
Oh, go
sarcoma.
ahead, yeah.
Once it's diagnosed in the eye, it's a very poor prognosis in our experience, and the time of survival is about 3 months. And we don't know whether there are cases that might develop primarily in the eye and then metastasize elsewhere, or whether the ones we see in the eye are primarily metastatic lesions. So it's hard to know at this point.
Yeah, we have an active project on those right now. Tanya Foster and might be able to answer some of these questions, or maybe not, depending on how the follow-up pan out.
Okay, sorry, carry on, Megan.
That's histiocytic sarcoma. Our next case is this kitty. So this is a 14-year-old spayed female domestic short-haired cat. This cat presented with blepharospasm, thick corneal vascularization, and severe corneal edema. They say bullous keratopathy, ? Lots of the things inside the eye too. Basically, things suggestive of uveitis. And the left eye is okay. There is a history of systemic hypertension, which is controlled. All right. Sort of the basics of the history. So looking at the gross image, we do have a lot of thickening and sort of tan tissue in the uvea here. We have this cornea here. It's very, very thick, opaque. And if you look at this eye from the front, it's sort of anteriorly bulging. It would sort of look like a dome-shaped cornea, even more so than usual, I guess. There is some cloudiness and liquefaction to the vitreous, but this structure here that you can see, it's sort of ghostly, like a little jellyfish back here. This is a detached retina, and probably very atrophied, although we need histology to see that. But it's there to see. So some of the basic features of the gross, let's take a look at the histo. Oh. All right. So on subgross, we can see this cornea that again is really thickened and sections sort of funny. It has a sort of mountainous looking shape, like that mountain from the Nightmare Before Christmas. Funny shaped. The uvea is pretty busy cellularly. We'll look closer at that. Here's that there too. And if you saw the gross, that sort of bulge of tan tissue that was in the anterior chamber, we've got that sampled in section 2, which we'll look at closer. And then here's that really weak, ghostly looking retina in the back. So let's take a better look at that outside of subgross. Lots of fun things to see in this eye. So starting with the cornea, I just passed over something interesting, but we'll start with this first. You can see that the cornea stroma, superficial to mid, is very pale staining. It's almost basically just clear space through here. And it's basically thickening the cornea with the amount of sort of clear space. So this is one of the few situations where we can actually call corneal edema histologically. Oftentimes they can be subtle histologically, and we may not necessarily be able to call it, but this is definitely corneal edema. And in fact, this is corneal hydrops. So very severe corneal edema. You may have also noticed that the corneal epithelium centrally is broadly absent. Nothing there. So there's also really extensive ulceration. There's lots of keratitis as well, but what I'll mostly show you next is that we have a clear reason for that corneal hydrops section as well. So here's Descemet's membrane coming in from the side, and then it's just curled up and broken and broadly dissected away from the middle of the cornea here. Doesn't come back in until way over here. And even then, it's still kind of dissected from the deep stroma. So we've basically lost that barrier function of Descemet's. We've lost the corneal endothelium that would have been actively pumping fluid out of this cornea. So this broad break and dissection of Descemet's is what would have led to this very severe edema in this cornea. This is also our first hint that probably at some point this cat experienced some degree of ocular trauma. That would be the most likely cause of this break and dissection of Descemet's. Coming down over here, we can see that the cause of the uveal changes on subgross are inflammatory cells.
I have a question.
Of course, go ahead.
Just with Descemet's membrane and how it's kind of curled on itself. How do you rule out that it's not just artifact from like just prepping this slide and
That's a
sectioning?
very good question. We do, so the question was, how do we rule out that that wasn't just an artifact in Descemet's there? So we do see artificial rupture of the lens not infrequently, a lens capsule, but Descemet's, it doesn't typically rupture artifactually. That said, the curling at the end of the membrane implies that there was some degree of force as it pulled apart. So the curling itself is one way to tell that it's probably an in vivo change. The other thing is that we do see a little bit of deep stromal reaction. I kind of skated over it, but
A little bit.
a lot of it. Good point.
There's a lot of deep reaction.
There's a lot of deep stromal reaction.
Yeah.
So all of this tissue through here, you can see that there's some plump reactive cells involved. There's a difference in the collagen character. It's a little bit more disorganized. So this deep stromal reaction also suggested that dissection was real and in vivo.
Yeah, the
So-
curling kind of happens because there's a inherent elasticity to Descemet's membrane, and when it's still attached to the deep corneal stroma, it obviously stay flat. And so if it is detached, like really detached, it kind of contracts a little bit on itself because of the elasticity, and then you end up with those cute little curls.
And after fixation, we wouldn't do that. So formalin fixation causes tissues to become more firm. And so if it's something that we did, either section it grossly or section on a microtome, if it ruptures again, it should not curl because it's already been fixed in formalin. There's probably a few exceptions to that where it might curl slightly, but rolling back on itself, it should not do after formalin fixation.
If the folks at home didn't catch that, keep in mind also that tissues become more firm at formalin fixation, so they won't typically roll if they've ruptured artifactually after fixation. I never know how much that stuff is audible on the microphone, but so hopefully I'm not repeating other people's better explanations. But anyway, so back to the uvea, we have a lymphoplasmacytic uveitis. It was somewhat plasma cell rich, but either way, it's inflammation. And that big ball of tan tissue that was in the anterior chamber turns out to just be fibrin, admixed with a little bit of blood, a little bit of degenerate neutrophils, some necrotic debris. If you thought by the gross photo that this may be something worse, it's actually just a pretty severe uveitis. This case isn't a great example of it, and the lens is sort of flipped around here. But back here, next to the posterior lens capsule, most of these are sort of reactive cells of some sort, probably macrophages or something else. Sort of in between those, there's this speckling of eosinophilic material in the anterior vitreous, which you may have to somewhat put on your imaginoscopes to see, but it's there, sort of this pink stuff back here. This is not a great case of it, but we sometimes see this eosinophilic material in the anterior vitreous of cats with uveitis. We used to think that it might be lens protein, but there have been some further research into this material. And it's probably not lens protein and may be associated with certain infectious diseases. So we typically, if they're not already doing it, which they often probably are, would suggest that they do a uveitis PCR panel for this kitty to take a look into potential causes of this uveitis. There's some degree of a cataract going on, but the lens is kind of awkwardly sampled, so I'm going to kind of skate over that. So here we have another example of retinal detachments. I won't belabor the retinoschisis, which is also here. Gillian's case already had a really good example of that. But we do also have tear of the retina captured here. You got this kind of lovely curl, and then this clubbed, sort of rounded end. It tells us that this was a true in vivo tear of the retina. And it's also severely atrophied, which contributed to its sort of translucent, ghostly appearance, grossly. Now let's see if we can catch some good vessels here.
I don't think I'd call that retinoschisis.
No?
No,
Okay, Gillian would
I'm
not
not-
call that retinoschisis.
I'm not sure what it is, but
Retinal edema, I think, kind of like retinoschisis, but it's a different pattern.
Retinal edema, they say.
Is
That
it
makes
just because it's like so atrophy that you can't tell where it's coming from, or is it like the fact that it's not like a band?
There's part of that location. Some of it looks like inner retina versus then the inner nuclear layer, outer nuclear layer. Some of it, it's just weird and different.
That's fair. I mean, there's also sometimes this sort of pale eosinophilic material in those spaces, which may also imply that it's edema. So good point. Probably more likely edema than retinoschisis.
It's a very gliotic retina, like
Yes.
happens in cats with chronic disease. If you do a Vimentin or GFAP on something like that, it will be like brown all throughout, basically.
So there was glaucoma. There's a slight cup of this cat's optic nerve. The lamina curvosa is slightly deeper than the level of the choroid. But the main reason why I'm back here is to show off this last key feature. So you can see, for example, in these central choroidal vessels, and there are a couple of other examples in this cat, the endothelium is here. Here's probably even a better example. The endothelium is here and like a single erythrocyte squeaking through the lumen maybe. But the rest of the wall is sort of glassy and eosinophilic. So this can be associated with sort of a degenerative change in the vessel walls, but it can also represent a serum insedation and some degree of remodeling of the walls. So this cat likely had some degree of vascular remodeling associated with the systemic hypertension that was noted in history. So I think that's all I want to show in this case. All right. So there's lots of diagnoses. The main ones that I wanted to show off are highlighted and made larger. So this is ultimately one of those idiopathic uveitis in cats, and it's kind of going to be on clinical corroboration to determine if we can figure out what origin or what's causing it. Because there is a cataract, the other thing that is possible is that it could be lens-induced. But ultimately, the cataract was fairly mild relative to the severity of the uveitis. And we had that sort of protein in the anterior vitreous. So that's about it. There aren't any other questions or comments. We'll move along. Oh, there's some chats.
they were saying thank you for
Yeah,
repeating the
repeating.
comments from the audience.
Oh, okay, good.
So continue to do that.
I always feel a little bit awkward. It's like the lady in Galaxy Quest. I'm just repeating what the computer said. Anyway, so the next case is a dog. Let's see what type of dog. This is a 12-year-old spayed female Schnauzer mix. So we have a left eye. They describe a pre-septal cellulitis, buphthalmus, deep neovascularization in the cornea. They suspect there was a rupture in the cornea. And then basically they couldn't see past all of this cornea badness. But they did say that there was a history of a giant retinal tear in this dog. Incidentally, they also mentioned that this dog has a 5 to 7 day history of listlessness or lethargy and increased tearing after a grooming appointment. However, I think that the grooming appointment was probably unrelated to what we ended up finding.
Can you make it full screen, Evan?
Oh, that's right. I should make it full screen. There we go. That's nicer. So here's the gross image. The lens is only not here sort of artifactually. I believe this is all just gel in the anterior chamber. But there was a lens, so not to worry about that. There may have been an anterior lens lux at some point in time, but it's difficult for us to tell. By the time that I trimmed it, the lens was luxated posteriorly and they couldn't see inside the eye. Although this sort of posterior bending of the iris leaflets suggests that it may have been in the anterior chamber at some point. This eye has this huge amount of thickening and tan change to the tissue in the episclera and conjunctiva, particularly on this side. On top of having some cloudiness of the vitreous and gel in the anterior chamber, there's also similar sort of tan material, and it's forming a bit of a carpet along the uveal surfaces, as you can maybe see. So that's this eye. We'll take a look at the histology. I will say for this eye, we did a procedure that we've been calling the Swiss roll, which basically means that we sort of released tension in the back of the eye and folded it a little to get it to end up in a mega cassette. So that's why the sclera kind of overlaps itself on this case. It's a good way of getting to look at more.
Think of the money we're saving. Think of not all those not extra large slides we have to store and blocks.
Yes, it's a storage thing. It's a money thing, and it basically is a nice way to sort of look at more on a average slide without disrupting the architecture too much.
For me, it's just an aesthetic thing.
It is not aesthetically pleasing. Yeah.
These are
Let go.
Easier to scan too, we someone in the audience said. So, all right. It is aesthetically not as pleasing though, for sure. So I probably won't stay on the subgross for too long. Here's that high cellularity in that tan tissue in the episclera and conjunctiva. The carpets on the uveal surface. Here's the lens out here with the cataract. Let's look at it with a better focus. There we go. So we're way back here in the peripheral cornea. You can see the nice stromal fibers and their arrangements. The inflammation that's here is pretty severe. You can see that it's basically distorting and thickening all of the tissues in this area. I'll take a closer look. And you can see that it's mostly neutrophils, necrosis, and then at the edges, there are often macrophages, if I could get there eventually. Lots of necrosis and neutrophils, some macrophages at the edges, and some lymphocytes and plasma cells as well. But ultimately, this cellulitis, while it was easier to see clinically, or episcleritis and conjunctivitis more specifically, is not the key feature of this case. So looking at the uvea, we've got the end of Decibel's membrane here to help orient you. And this would have been the angle, but it's covered by peripheral anterior synechia. And then we're coming into iris here. There's a really thick inflammatory and fibrovascular carpet on top of this uvea. So basically this is a fibrovascular membrane that's admixed with tons of lymphocytes and plasma cells, but then on the top is the really key feature. We have this carpet of epithelioid macrophages. So they are called epithelioid because they look like an epithelium almost, the way they're sort of plump and forming rows or layers. But these are macrophages, and we'll go one closer even to take a really nice look at this lovely pattern. They're associated at their tips with a couple of neutrophils, and there's a little bit of a fibrinosuppurative endophthalmitis going on as well. There's also, in this case, pretty extensive uveal necrosis. So you can see that the pigment here is sort of floating around. There isn't really discrete epithelial layer anymore. So really severe lymphoplasmacytic panuveitis and a granulomatous and fibrinosuppurative endophthalmitis with this pattern of epithelioid macrophage carpeting. And the epithelioid macrophage carpeting is very important. The other feature that is useful in this case, let's see if I can find it. Actually, we'll get into it up here. No. There's a lot of these globules of protein around, which aren't really fibrin. There are probably some better examples, but this is okay. So they form up with these sort of round, more brightly eosinophilic globules and the fibrin that's surrounding. And then macrophages will tend to respond to these globules and are actively phagocytizing them. They look like dead cells to Gillian. I'll find a better example. They could very well be dead cells. I need to find a better example. See if there's some
Is there
next to
anything
the lens.
attached to the lens?
Yeah, that's what I was gonna. Let's see. There we go. That might be much more rewarding. Maybe.
Skeptical Gillian is skeptical.
I think your skepticism is fair. So they could be dead cells. I swear that there are better areas, but when I'm in the hot seat, sometimes I don't find them.
Definitely believe you. It wouldn't be unexpected to find them here. Oh, there it is.
Yeah, these are probably much more believable. So see, these
Yes.
pink globules here and here, they're a little bit too big to be dead cells, at least. Some of the rest of the globules may well be necrotic cells, though, for what it's worth.
It's also very homogeneous pink. It's not granular the way the others were.
Yeah.
They're larger, yeah. Okay.
That is fair. So basically, this is most likely lens protein that has leaked through the lens capsule. We see macrophages responding to it and phagocytizing it, although probably not in this field again. This is why I should probably circle a field or something like that in advance. So we have this pattern of epithelioid macrophage carpeting. We have lens protein free inside the eye, which is being phagocytized by macrophages. And these two features are very supportive of the diagnosis of asymmetric uveitis. So asymmetric uveitis is somewhat Coplow specific. There are probably other pathologists out there who would just refer to this as a bland phacolytic uveitis. Phacolytic,
Not bland.
not bland.
Just, yeah.
Severe phacolytic
There you go.
uveitis. Sorry, they would probably refer to it as just a severe phacolytic uveitis. Bland, I guess, is another thing that would be more Coplow-y to distinguish it from asymmetric uveitis.
You can just call it a lens-induced uveitis.
Or just a lens-induced uveitis. There you go. Regardless, it is a lens-induced process. On that, I think most people can agree, which is important because cases like this may kind of make you wonder about infectious agents, but just remember this pattern in terms of lens-induced processes. They can be quite severe like this. Everybody probably agrees that this is a lens-induced process, but what we find is that with this specific pattern of epithelioid macrophage carpeting, the other eye in these patients tends to develop a really severe lens-induced disease at some point down the road. That's why the term asymmetric uveitis is used. It refers to both eyes eventually being involved, but like it's an asymmetric presentation. Kelsey Brakel, who is just here, was plumbing for it to be called asynchronous uveitis. And David says him too.
Oh yeah, that comes way before Kelsey.
Oh, way before Kelsey even.
Where we talk about
Yeah, the name, yeah. Because basically it is symmetric disease, I guess, in the sense that it tends to affect both eyes, but it's an asynchronous presentation. It's the time that's sort of asymmetric. But so regardless about the debates over the name and whatnot, Coplow is working on publishing this. And it does typically present an imminent risk for vision and the other eye. And the case can be potentially maintain vision for a longer period of time if the other eye is placed on prophylactic anti-inflammatory medications, particularly if the other eye has a cataract already. So one thing I also didn't say is that the reason we think this happens is it's some sort of hyper sensitive reaction to lens protein. So like a phacoanaphylaxis of sorts. All right, I think that's all I want to show. So let's jump back to the PowerPoint. So that's asymmetric uveitis, probably one of the more severe cases that you'll ever see. And that's it.
This is suggested type 1 hypersensitivity. We think it is a type 1 hypersensitivity.
Yeah, you know.
Yeah, I think that term was kind of taken from human literature. That's how they started referring to it early on, is the pickle anaphylactic or adopted the term. But
We
no,
typically,
not type 1 hypersensitivity.
we typically don't use the term fecal anaphylaxis in our reports. We call it a presumed hypersensitivity, and that's it. But yeah,
So very, yeah, don't want to add to the
the naming
contentious
confusion.
nature of the
Yes.
naming already.
It's a contentious situation.
Yeah, I'm just gonna put my name on it, you know, Teixeira-de-Busick syndrome, and Dan will piss everyone, especially because they would not know how to spell it or pronounce it.
Two fun names.
Like Kokoyanashi Harada syndrome. You know? Let's make it even worse than that. Okay, my next case is this feller here. It's Henry. Henry is, can you get this thing to go away? Oops, nope, that's not what I wanted. Okay, where are you, Henry?
Henry's
Oh, yeah, it's a rabbit. 4-year 4-month-old rabbit. They describe bilateral.
You're on the next case. We need to go back. There you go.
All right, got it.
And just to let you know, Leandro, the audience out there can't see.
Yeah,
it.
I just
Okay.
wanted to confirm
know
the
it's-
right number.
Oh, got it,
I
got it,
know
okay.
that. I know that. 4-year 4-month-old rabbit. We got bilateral history of bilateral glaucoma. Manus and Dazzle negative on the right eye, which is the one we have here. Anterior uveitis, corneal edema, incipient cataract. They want to rule out a primary versus secondary glaucoma. Okay, so this is what we got. A rabbit eye. Not much to look at, to be honest. A beautiful example of a rabbit eye. You can see a little bit of the medullary ray here. Rabbits have this very specific fundoscopic appearance where they have a horizontal line of myelinated fibers in their inner retina that extend into and over the optic nerve. It's a very pale back and our fundus, but yeah, there it is. Let's see if we can see it histologically. So here's what it looks like on subgross. Let's orient ourselves a little better. Okay, front of the eye. Here is the lens. Iris leaflets. You can see how in rabbits the first plique of the ciliary body kind of starts at the base of the iris. It's a little bit more forward located, and that's a normal feature. Right in the back. We have a section right through the optic nerve, and we have an extra banana section of that angle. I was having rounds with folks at Davis yesterday, and they started doing that, and they also call it banana sections, which I think it's a good thing. We're propagating one way to call those things. Okay, so here is just a little bit. Here's the eye. Corneum. Yeah, not much, maybe a little bit of edema. You can see kind of a pale appearance of the corneal stroma, but not really. Again, it's really hard to tell histologically. It's a very large eye for a rabbit, so likely both thumbs. When we get to the angles, now that's where comparative anomaly in this case, but anatomy also comes in handy. If you compare this to a normal iridocorneal angle, there are lots of things we don't see. Again, end of decimus brain comes around, there's no obvious ciliary cleft or pectinal ligaments. Everything here is somewhat collapsed. The ciliary, and again, the ciliary cleft is not obvious. The trabecular meshwork is not obvious. And then the aqueous drainage structures are also not easily identifiable. So there's something wrong with that angle. Another thing to keep in mind is the fact that there's not a lot of reason why this angle is collapsed, meaning there's not an obvious fibrovascular membrane with a peripheral anterior synechia. So nothing that justifies that angle. The good thing about a case like that is that we have actually two more angles to take a look at. Here's the other angle, and you can take sort of the same approach. Again, a tapering of that end of decimus membrane. See these areas like tissue coming around, contacting that tapered end. There's no obvious pectinal ligaments. If you use your imaginoscope, you can kind of pretend you're seeing the cleft over there, but everything else is collapsed and nothing of the aqueous drainage structures right here. So let's go to the third one. Here it is. Similar situation. Tapered end of decimus membrane, no obvious ciliary cleft or trabecular meshwork. Right, if you keep going down, really hard to identify any of the aqueous drainage structures. So it looks like we have another congenital abnormality here, or a malformation of the iridocorneal angles. So anterior segment dysgenesis or goniodysgenesis. Kind of depends. You know, the nomenclature in rabbits can be a little bit hard to define because there's not a lot described, but you know, one thing here, we don't have a specific time of onset of this disease. They only said months, and it's a 4-year-old rabbit, so a little older than you would expect. The lens is markedly shattered, and so there might be some changes there, but they're not obvious. And in terms of retina, we don't have an optic nerve in this section, but we do have the retina, so we can take a look at it. Their main concern was glaucoma, and we have to confirm the presence of glaucoma. So we are at the peripheral retina, so take that with a grain of salt. Don't try to overinterpret retina at the periphery because it looks much more atrophy than normal. But here we're getting a little bit closer to the central retina, and I'm still waiting to see a single ganglion cell, right? We joke that the hardest thing to see in pathology is what's not there, right? So there's not a single ganglion cell for you to look and compare to in another area. So it's basically, these smaller guys here are not ganglion cells, they're too small for that. So complete loss of ganglion cells. So inner retinal atrophy with that change in anterior chamber, so goniodysgenesis / anterior segment dysgenesis for this rabbit. Go back here to the part point. Yep, so chronic glaucoma associated with goniodysgenesis. So primary glaucoma. The other eye is already affected, as they have described, so it's very likely that this disease is bilateral at this point. What are we doing here? I got 5 minutes. All right. Let's play fast pathology. This is Bowser, the 3-year-old Maine-neuter domestic short-haired cat. We got the right eye, IOP of 58, ophthalmos 360-degree perilimbo endothelial opacification. Sure, you're not going to be able to see here. There's a deep anterior chamber, mature cataract. And they describe, which is kind of fun because we can see it here, multiple iris to lens persistent pupillary membranes versus what they said posterior or anterior synechian.
Iris the lens, so.
Yeah. I am seeing going the other way.
Yeah.
Subluxation of the lens. Not able to see the fins. So look how cute these are. They have these multiple. So here's the iris, the cornea. It had these multiple thin black tendrils that extend into the anterior chamber and contact to the posterior aspect of the cornea. So these are the persistent pupillary membranes. You don't need to be a board certified ophthalmologist or a pathologist to see that that lens is not normal. So markedly cataractous, very opaque. There is a markedly expanded posterior chamber here. You can see how the ciliary body processes are elongated. And here's the back of the eye. So let's take a quick look at it. 1916. Here we go. Eye on subgross. Not the best view that we can get, but we'll get there. You can see the cataractous lens. You can see the iris profiles and the markedly expanded sort of posterior chamber. There is a nice looking linear structure coming around here, so we'll take a look at that. And no optic nerve on this section. Okay. All right. So unfortunately, those very cute looking pupillary membranes were not sampled histologically, and you can imagine how hard it would be to section through some of those very thin tendrils. Sometimes what you see, if you look in the anterior chamber, you see kind of cross sections, kind of rounded black, uveal looking tissue, sort of free floating like tiny islands. Or you might be able, if you're lucky, to see that tissue connecting to Decimus membrane. But we were not lucky this time. But anyway, keeping up with the theme here, congenital ocular disease. Here's another one of those, right? So I'm gonna beat you guys to death with information on malformations of the angle. So here's Decimus membrane. It tapers again, and it morphs into this nothingness of your corneal angle. It's just basically the same tissue as the iris leaflets, or the iris stroma, sorry, that's what I meant. And no hints of a ciliary cleft or a trabecular meshwork. The collecting channels are way back here. Start seeing them when you start seeing the plica. So there's a posterior displacement of it, which we don't know necessarily if it's just part of the malformation or it has to do with the ophthalmos and the distortion of the tissue as well. On the other side, even better. It's an iris-like tissue coming around and of Decimus membrane, and we don't get to see much right there. Here. Oops, went too far. Here's the lens. Now that is definitely cataracts. It's a relatively young cat. To have like such a significant cataract strongly suggests that this was a congenital cataract. So there are areas of mineralization and liquefaction, extensive liquefaction of the lens fibers. There is somewhat a loss of polarity of those lens epithelial cells where there's no obvious lens bowl, which is sort of a feature of congenital cataracts. And then more towards the back, we don't have an optic nerve, so we don't have an optic nerve connection here. There is the tapetum right there. And floating around is a phantasmagoric retina. Not much left, just thin tendrils of neural pill-like tissue that stretch around. I think we had probably all the whole spectrum of retinoschisis and atrophy today. We had that one from Megan, that's just a little bit of demodeline there. Classic one from Guillem, and this where it's just like holes, edema, and just a very atrophied retina, almost like just the glial scar, kind of connecting to the other side here at the oris areata. Right, so again, congenital glaucoma, anterior segment dysgenesis, there's a retinal detachment and atrophy. This could be a dysplastic retina. One of the things that we see with some of these guys, especially in cats, what we call the feline vitro fibrovascular vitreoretinopathy, something among like that. I never remember the name of that, which is a we think it's a dysplastic congenital abnormality of the retina where the retinal vessels don't develop perfectly, and then you have a neovascular reaction of the retina into the vitreous, which we don't have here. And the only reason I'm pointing that out is because a lot of those cases, cats also have anterior segment dysgenesis. So if you get something like this, check for anterior segment dysgenesis, and if you got anterior segment dysgenesis, check for a particularly avascular retina. In this case, you can actually see the vessels in the retina, even though basically I think the vessels are the most impressive thing that's left in this retina. So I might go against that diagnosis. So let's see what we call it. Yeah, anterior segment dysgenesis, iris persistent, iris to lens. In this case, more likely iris to cornea, but we said as per history, so we wrote what they said. And glaucoma as per history. The reason we were not able to confirm the glaucoma is that we didn't have the optic nerve in this section, and that retina was gone. So that could have been a dysplastic atrophic retina, but very, very likely a congenital glaucoma or a juvenile glaucoma in this case. All right, that's our time. Thanks, everyone. And we'll be uploading this video soon to YouTube. See you guys in 2 weeks.
You. All right, necropsy bolts. We have no necropsies for today so far. So let's take a half-hour break and then get over the.
Should we just end here? You know, do I have to save that part?
We don't have any cases come in by noon. I'll probably bring a look at the presentation.